prompts research and treatment. Thank you very much.
Paul, that was great. I really appreciate such a comprehensive description of where we're stuck in psychiatry. I've gotten several wonderful questions during the course of your discussion,
Okay.
but the first one that really is perfect for us to start our conversation is this. It's this question: if you use all of the HIDE elements of the mnemonic, if you look at the disease, the personality and temperament, the life story, and the behavior of patients, does this not degenerate such a complicated decision tree that it becomes unwieldy and too large to manage? And I think that's a great question, because it's the core feature of what we struggle with.
Yes, right, yes. Well, what it certainly does do is that once you begin to realize that these elements could be present in a particular patient, it leads you to really work the patient up from the bottom up, rather than to be satisfied with a checklist that we're being promoted. I have to tell you that prior to DSM-3, in all of the textbooks in psychiatry, both here and in Britain, the Larry Kolb textbook, the Meyer, Gross, Slater, and Roth textbook, the introductory chapters fundamentally tell you how to take and examine a patient and study a patient from essentially conception on. It does take a lot of time, and there are complexities in your decisions at various times out of that information. But through that body of information, you can quite easily not only see and differentiate patients according to these perspectives, but you can often see how several perspectives are in play in this particular patient and which call for understanding. Just take the condition like PTSD. By the way, it's important to know, I am not saying that PTSD doesn't exist. Of course PTSD exists, just the way grief exists, all right? But it's not the only explanation for everybody who has been in the armed forces. They suffer from other conditions as well. But if you had a case of PTSD, or you had a patient in which it's clear that distress has come from something they encountered, it is useful and would be clearly seen as you work with such patients that appreciating that some of the trauma may have been due to the experience that they provoked by the behaviors they choose, and some of the reaction could be due to the intensity of the feelings that they have towards everything that happens in their life. And therefore, helping them by telling them that this is a normal reaction, but also telling them that the kinds of behaviors that have exposed them to this, and understanding who they are in such a fashion that would explain how long it's taking for things to improve, would be a great aid to that patient. We're often asked simply, is this too tough a thing to do? Well, I do want to tell you that it's more tough than a checklist, but it is far more illuminating and illuminating to both yourself and your patients. We are often said that the insurance companies and the health system will not support this. Well, they won't support this because for 30 years we've been telling them that we could get by with checklists, and we're not succeeding. Now is the time for us to begin telling them, and with our patients' support, what we need to do to make coherent, thoughtful, and agreed, complicated formulations of patients rather than single diagnoses.
Great answer, and exactly kind of leads into the next question. Mm-hmm. One of the audience members, Dr. Mello, asked, when you use the term neurotic, which you used frequently in your talk, how do you fit that term in with what we're talking about? When you use the term neurotic, what are you getting at?
That's a very useful question, and I should have, if I had longer, I would have discussed where I'm using it. You remember, of course, that neurosis was thrown out of DSM-3. I am using the term neurotic from the psychology literature, really fundamentally beginning early with Wundt and all, but crystallized by Hans Eysenck when he was talking about the dimension of stability the universal dimension of stability by which people could be classified, just as they can be classified according to their weight, their height, their intelligence. So they can be classified as to stability or instability, weak or strong emotional reactions to situations. And Eysenck began to use the term neuroticism to describe that dimension, just like IQ is to describe the cognitive power, and said that high neuroticism was a problem in many of the patients seen in psychiatric clinics for psychotherapy, and that is that they had intense unstable personalities or intense emotional reactions, strong emotional reactions to stimuli in the environment, in contrast to ordinary, to the average person whose reaction was not that strong. And it is exactly a useful term for you. And by the way, often at Hopkins, we instead of using the term neuroticism that has this tradition, just use the word unstable, speaking of a person being an unstable extrovert, by which we mean that he's extroverted, but his emotions are strong, and in contrast to the stable extrovert who has weak emotions to ordinary situations. So that's what it's meant. It's meant a grading of emotional strength.
Right. And one of the things that I like to emphasize when I'm talking about personality is the idea that all these features of personality and temperament are strengths in one environment and vulnerabilities in another. So their naturally evolved traits are good if in the right environment. So I don't like the term neuroticism. I like the term instability, since it implies that being emotionally reactive isn't all bad.
No,
it's sometimes it's good. And,
I think you're probably right there. So you prefer to use the word unstable or unstable.
I don't tell patients they're neurotic. I tell them they're unstable, and I describe them. I say, look, you have a big emotional reaction to modest emotional stimuli, in contrast to people who have a modest emotional reaction to big emotional stimuli, which is why you have such difficulty with emotionally intense situations. But in other situations, you read the emotions of others well, you're empathetic, you can lead a group, you sense the emotions of the people in the room. My patients always say, you are like, and you have these moth-like antennae for other people's feelings. And they say, that's exactly what I'm like. And
that's very
I think that's helpful.
I think that's very wise.
Now, another thing that someone asked, this is Dr. Dow's question, is, isn't this perspectives approach, the Hyde approach, another version of the biopsychosocial?
Yes.
And we've heard that question many times, so I think that's a question to discuss.
It's a splendid question to discuss. Yes, indeed. It's trying to bring you back from where Steve Shafstein says you are, the bio, into a biopsychosocial. But what it's striving to do, which the biopsychosocial approach didn't do, was to give you the domains, the particular kinds of ways, the ingredients or causal ingredients in the biopsychosocial domains could be translated into causal networks of influence. At one level, no one could say anything better than Engels said, copying fundamentally Adolf Meyer by saying, we should be searching in the biological domain, the psychological domain, and the social domain for our studies. This would apply to everybody, as Engels said. But what we really need to know is how what's going wrong in those events can be what's going wrong in the patient, what the patient is demonstrating, how we can derive that problem from particular elements within the biopsychosocial domain. Knowing that a molecular problem can affect somebody doesn't evoke much from medical doctors. You're supposed to tell them what molecule and how the molecules have produced this condition, how this condition is derived from that center. The